Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the NICU. And today we are kind of sticking with our unexpected theme. Didn't really plan this as well as I thought I did, or it appears that I did, of a lab value, and we're going to talk about blood sugar management. So we've talked about sepsis, and we've talked about blood transfusions and total fluids, all these things that kind of rely on the labs that we draw. So let's talk about our blood sugar and kind of what that means in the NICU. So one thing that I think is really interesting is it feels like, oh, there's always these different ranges for what's a normal blood sugar. But at the end of the day, I reread a ton of research over the last week, and really this is what I'm finding, is that normal blood sugar really is between 50 and 120. If it's less than 50, we're starting to get concerned, but if you're 48 with no symptoms, probably not as concerned. If you're less than 40, we're concerned. If it's greater than 125, really pushing up there depending on what's going on with the baby, we're starting to get concerned. If the baby's stressed, if they have excessive glucose infusion, what's going on with the baby, and then knowing kind of how long should we check after it becomes stable. And really what we're seeing out there is that really for 24 to 48 hours after getting your stable blood sugar, we should be continuing to kind of watch and monitor. So let's kind of break this all down. When we think about our preterm infants, so preterm technically means born before 37 weeks. We do have that preterm less than 34. Late preterm is the 34 to 36 and 6. But for those babies, really, we want them to be between 40 and 60 on that first day, depending on if they are late preterm and we're giving them some food, or if they're surviving on all IV fluids. And then after that, really 50 to 90. Babies that are on full TPN typically are going to range a little bit higher in that 80 to 100 as a normal because they're getting a continuous infusion of dextrose. Preterm babies who are getting some feeds or maybe are getting Q3R feeds may, kind of hang out more between 60 and 80. We really have to develop or to check their blood sugars more often in those first few days of life because of their underdeveloped glycogen storages, and then obviously we can't feed them very well. Term infants, we're definitely going to accept those values closer to 40, especially if they are feeding, breastfeeding, kind of seeing what's going on with them. And then again, their values are going to kind of stable more around that 50 to 60 range. If a baby is term baby and has risk factors such as IgM or LGA or even a difficult delivery which can cause stress, we may need to be checking them more often, up to 48 hours and not just for the first 24. Those post-term infants, we really are kind of watching for what happened to them in that time period following delivery and how can we best support them. So their values are they're what we would consider normal, would be similar to a term infant, but they're going to require more close monitoring than a term infant would. So let's talk about hypoglycemia first. We're going to kind of dive into this and then look at some different pathways and just talk about tips and tricks. But hypoglycemia is really that blood sugar less than 40 in the first day of life and less than 50 after. Again, your unit may have specific protocols. On my unit, we really talk about 60 to 120, and then if we're at 50, we would be calling but maybe not treating, and then considering, hey, what do we need to do for if the baby is symptomatic or not. Risk factors for hypoglycemia are going to include prematurity, maternal diabetes, intrauterine growth restriction, sepsis, hypothermia. We have babies admitted to the NICU from our postpartum or mother baby unit, and they're admitted and they have some breathing difficulties, but what we soon find out, if they're cold, their blood sugar's low, everything else is kind of going out the window there. Symptoms are going to include jitteriness, lethargy, poor feeding, and what we're going to see on the next slide is for some of these babies, especially our late preterm infants, if they're not symptomatic, we may not treat right away. Some other causes could include poor absorption, delayed digestion, IgM, inborn errors of metabolism. These babies that really maybe are premature and we're continuing to see what's going on with them. Maybe they're premature and we've had stable blood sugars for 3 to 4 weeks and now we don't. Really kind of needing to be thinking about what's going on with them. So our immediate action is to get some feeding started whenever we can, to give glucose gel for those babies that are late preterm or term, to consider IV glucose boluses for hypoglycemia for our preterm babies that aren't on feeds, we're giving 2 mils per kilo of that dextrose, usually over 5 minutes or via IV push. Ongoing care is to continue those regular blood sugar checks, which we're going to talk about on our next slide a little bit. This idea of, hey, do you have a policy, a protocol, something in place? So these are just some samples that I found out in the universe, but really this kind of idea that if your baby's blood sugar is less than 40 and they're symptomatic, that we need to be doing something quickly. If they're asymptomatic, we're kind of then going to break them up in this idea of, are you in that birth to 4 hours or are you greater? Otherwise, we may also look at, can we feed or not? And if a baby cannot feed, again, we're going to be starting to consider, what do we need to do with our GIR, and do we need to be giving this baby a bolus? So our goal really is at 60 to 120. Some facilities may be accepting 50, and then definitely down to 40. I think there's also this kind of threshold to treat and the threshold to notify. So we may notify a provider when a blood sugar is less than 60, but may not expect a treatment unless it's less than 50. Similarly, we may not notify until it's less than 50, and then not treat until it's less than 40. So know your policy for that. On admission, you're going to want to be checking blood sugars more frequently. So might be, when they're born, and then every 1 hour until you have 2 stable. It might be that you had one, you had to treat with a D10 bolus, and so now we need to check again, whatever might be going on there. We also want to make slow changes to our total GIR, our glucose infusion rate. We're going to talk about what that is a little bit more in a few slides, or to our feedings, and then watch for symptoms. Interventions, obviously we want to get D10 going. Our goal is always within 60 minutes. We want to bolus D10 at 2 mils per kilo if needed for low blood sugar, especially in non-feeding infants. From D10, we would go to D12. Remember, if we are going to go above D12, we need to place a central line. That dextrose-containing solutions above D12.5 is really too viscous for the vein. So we need to get in a UVC or PICC line or whatever it might be at your facility to go up to D15. I've seen babies up on D20. These babies that are typically D15 to D20 tend to be the IDM babies, right? So their body is kind of used to this different level of sugar. We have a high level of insulin, and it's just kind of like attacking everything that's going on there, hyperinsulinemia, to cause our low glucose. So obviously we also want to begin our feeds ASAP as indicated, depending on the baby. So let's talk about hyperglycemia. So this is when our blood sugar rises above 125 and kind of sustains there. I was reading reviewing some articles for this and really talking about kind of what the stress response does, right? So stress sends out cortisol, cortisol increases your sugar, and stress for babies can be really transient or long-term. So if you check a blood sugar 10 minutes after an intubation, you may anticipate that blood sugar is going to be high, and it might not be something that we're going to treat. But if your baby's, blood sugars have been rising steadily over a few hours, and now we're at 150, 175, 200, then we're going to get to this place where it's time to treat. Obviously, this is very common in premature babies, low birth weight, IUGR, any amount of stress. This is a sign of sepsis. It can be a sign of NEC, is when a baby's blood sugar goes up as a response to the stress. I always say, if you are concerned that something's going on with your baby, you should be getting a blood sugar. It's going to tell you a lot about what's going on with your baby. So our treatment is going to adjust the glucose infusion rates whenever we can. We're going to do that before we start insulin. Insulin, as a bedside nurse, is a tricky drug to give because it seems like once it hits the baby, we are weaning quickly. So we always want to think about, what can we do? Are there any underlying symptoms or causes? Is the baby having seizures? Is something else going on that we could be helping the baby in this regard? Obviously something like NEC, do they need surgery? So regular monitoring of the blood sugar is going to prevent that complication. We need to be watching for dehydration. We need to look at our electrolytes. And as soon as we can get the baby onto full feeds, that's going to help. So again, we have some treatment pathways here. Our goal is for our blood sugar to be less than 125. So we really have this idea that, hey, we're going to probably need to work on our glucose infusion rates, know what your GIR is, know what your total fluid goal is for your baby. This goes great with what we talked about last week. Knowing what your baby's total fluids are is a game changer. understanding your insulin rate, understanding how we give insulin. So if we've decreased our GIR as far as we can while still giving the baby nutrition, we're probably going to start insulin. Important thing to know about insulin is that it needs to bind to the plastic of the tubing, and so you have to prime it for a period of time. I worked in one facility where the pharmacy primed it before they sent it to us. So it was already primed in the tubing. It has to absorb anywhere. The literature will tell you from 30 to 60 minutes before you can really start it. Otherwise, it's just starts binding into the tubing, and then the baby never gets it. So you have to let it sit there for a period of time so then the insulin can come through. You're going to make micro changes to this. I've seen babies have a quick reaction and their blood sugar bottoms out. And just like anything, we've talked about this with blood pressure in the past, huge waves when we're like, okay, our MAP's 24, our MAP's 44, our MAP's 24. Same thing with your blood sugar. If your blood sugar is 300, we don't want it to come to 40. We want it to go 300, 250, 200, right? We want to do these gradual decreases. That's going to help the baby and make them much more steady. I do want to point out that like this idea of the GIR is not something that we all just kind of quickly know and understand, depending on the unit you work on and kind of what you've experienced. So let's talk about the GIR, right? I was saying DIR, dextrose infusion rate, glucose infusion rate. So it's the glucose infusion rate. The glucose infusion rate is this idea of kind of knowing how much glucose your baby is getting in them and not just in the total fluids. So we talked last week about total fluids, which is something we're going to need to know here. But let's go ahead and give ourselves a sample here. So we are going to have a 3.8 kilo baby. So we're going to think about a baby who might be IDM, just going to be an older baby. They are getting 80 per kilo. And that's coming out to a rate of 12.7 mils per hour. And they're on D12. So this is a sick term baby, and their blood sugars are rising, rising, rising. You would see this maybe in a cooling baby and someone with a seizure. So we want to lower our glucose infusion rate. So first we need to know what it is. So let's talk about it. Let's do our first calculation. So our glucose infusion rate is glucose percentage, which is 12, times our mils per kilo per day, which is 80, divided by 144. So if we did 12 times 80, let's get out our trusty calculator here. 12 times 80 on top, we would have 960 divided by 144, and we're getting 6.7. So our GIR for this baby is 6.7. Our GIR, if we did it the other way, so let's do it with our other calculation. So we're going to take our rate, which is 12.7, times our concentration, times 1,000, divided by our weight, which is 3.8, times 60, times 100. So that gives us on top, we're going to have 12.7 times 12 times 1,000 is 152,400. I know how to read. Divided by 3.8 times 60 times 100 is 22,800. And when you divide that, you get 6.7. So personally, if it were me as a regular lady over here, I would take this one. It seems much easier to do as long as you know what your mils per kilo per day. So little insider tip here. If I was just told that my baby was getting D12 at 12.7 mils per hour, I would take that 12.7 and times it by 24. 12.7 times 24 is 308, and then divide it by my baby's weight, which is 3.8, and that tells me 80. So divided by the baby's weight, so that's mils per kilo per day if I did not know. So that's kind of how you would do that reverse math to get the 80. So this number right here is the 80 here. So if you don't know how much fluid your baby's on, you could go ahead and look in your provider note, look in your order, whatever your unit does, but then you could also do some reverse math. When we're talking about our blood sugar, right, we really need to think about what we're doing on admission. So we got to check that sugar right away. I tend to be the person that says we shouldn't check your blood sugar until you have access, because what are you going to do if it's bad? It always stresses me out. Like if I'm setting my priorities in an admission, my priority is to do a quick listen, get a temp, get my servo skin mode on, and start looking for an IV. If there's going to be a UV, even better. But getting a blood sugar just in the setting of a blood sugar just stresses me out if we have nothing we can do for it. If it's low, which is more likely during admission, it's much more likely to be low than high. You're going to give that D10, so 2 mils per kilo over 5 minutes, and recheck 30 minutes later. Get that IV fluid started within 60 minutes of admission. That's part of your golden hour checklist. And then check hourly until stable or per policy. Ongoing, if your baby is on fluids, you're typically checking every 8 to 12 hours. If you're weaning it, you could have orders that are weaning your fluids based on what your AC sugars are. So typically that's going to say if your sugar is greater than 60, wean your rate by 1, or whatever it might be. So knowing exactly what your order says so you can speak to that in regard to your blood sugar. Once you're on all enteral feeds, you're probably only checking it with labs or PRN. And again, anytime your baby is showing signs of sepsis, neck, acting differently, check a blood sugar. You should always have a standing PRN order. That is your nursing judgment to figure out if there's something else going on, and that will tell you so much about your baby. What do we want to tell our parents about this? So with the preterm or late preterm babies, it's also just kind of why we can tell them that they're on certain dextrose, why we're making changes to their fluids, why we're weaning or increasing them, why we have to get the labs that we do because babies change so frequently. What are our expected interventions? What are we going to do if it's low? What happens if a baby needs more dextrose? Do we going to have to put in a central line? For term babies, so whenever a baby's admitted to the NICU just for low blood sugar, especially if they've already been with mom and dad, I feel like those are so tricky and so emotional because they kind of feel like they've already finished, all the hard things and they have their baby and now they're having this separation, which is trauma, and it can cause PTSD to have your baby pulled away from you. It's just terrible. So we need to tell them how often we're going to be checking it, what we're looking for in order to wean their fluids, if they are going to need a PIV or have to have a central line put in, what their path towards discharge is, how are we going to get feed started, what our feeding's going to look like. For some babies, we may have to use some formula to get through a gap of time, and that could be another thing that the parents have to let go of. So telling them expected outcomes and how long that we think this is going to take is going to really ease their worry. I never say it's going to take it away. It just may make them have a better understanding of the plan of care. So our job is to regularly monitor the blood sugar. We need to address hypoglycemia, especially if it's less than 40, address hyperglycemia when it's greater than 125, never forgetting about the role of stress in blood sugar management. I say that also to remind you that if there's a stressful situation, such as an intubation, and your blood sugar is higher, it may bottom out when your cortisol level drops and you're not pumping out glucose. So keep that in mind. I've also say this after a code, right? Your blood sugar may be high and then bottom out again. It may also be low because your cardiac, muscle has been using so much sugar. So just things to consider, that a stable blood sugar in the setting of a traumatic incident isn't going to tell us the whole story. So make sure keeping an eye on them, watching for signs and symptoms, documenting accurately. If you call your provider and say, hey, this is my blood sugar, make sure you're documenting it somewhere, especially if no intervention is ordered. That wraps up today's Teach Me Tuesday. I will be on vacation next week, so there will be no Teach Me Tuesday during the final week of July, but I will see you again in August, where we are going to have a lot of fun stuff going on. If you're not already following me on Instagram, you can find me at Houston_we_have_a, just like my YouTube page, where you can be entered into lots of drawings in the month of August. And I will see you then, and have a great Tuesday.